Hi, my name is Kirsten Eagles. My student number is T00698082. And today in this video, I'll be doing a CPR demonstration with some of my coworkers. So first off, to kind of discuss some things. So first we want to discuss a bit what position our patient should be in. So we want our patient in lateral recumbency. And then for compressions, we want to make sure that with our Labrador patient, or like a medium to large size dog, that we're doing it over the widest portion of the chest. So we're doing like the thoracic pump. The rate we want to do it at is going to be 100 to 120 beats per minute. And then recoil, we want to, or the depth, we want to do 1/2 to 1/3, or 1/2 to 1/3 of the patient's chest depth. This is going to allow full compression of the heart and to help improve blood flow through the heart as we're doing our compressions. For intubation, we want to keep our patient in lateral as well because that's, we don't want to be stopping our compressions to take time to intubate. We want to keep up with those compressions. So while we're doing the compression, someone else will be intubating. For bagging our patient, so we want to make sure that we have 6 seconds in between breaths. So that gives us our rate of 10 seconds or 10 breaths per minute. We want to make sure that our inspiratory time is only about 1 second. We want to make sure that we're not giving too large of volumes as well, or hyperventilating our patient, because those can both in turn decrease the actual venous return to the heart. So we want to make sure that we're doing those properly, not going too fast, not going too slow, and not going too hard. And then 2 pieces of monitoring equipment that we want to make sure that we have. So the first is ECG. So ECG is kind of one of the main important ones because that'll tell us whether or not we have a heart rhythm, what the heart rhythm is, what our heartbeat is, and whether or not it's a shockable rhythm or not. So ECG, super important. The other is our end tidal CO2. So that we want to put in between our ambu bag and our endotracheal tube. So that's going to tell us how effective our compressions are. So we want it greater than 15, and that'll indicate that our compressions are good. If it's less than that, we want to go harder and we want to go faster with our compressions. So how to gain vascular access. So a couple of options for vascular access. You can do cephalic vein, you can do saphenous vein, you could do jugular vein, or like a central line. If that can't be gotten easily, you can perform a cut down. So what a cut down is when there's an incision made over top of the actual vein itself, just so that the vein is a little bit easier to visualize and be able to insert the catheter that way. It is a fairly sterile technique, but it's not fully sterile. So we want to avoid it if we can. As well, if we perform a cut down and you still can't quite visualize the vein, you can take hemostats and sort of spread the fascia from the vein and lift the vein up slightly to be able to insert your catheter that way. If we can't get any vascular access at all, there are some other options to be able to administer drugs. So there's intraosseous and there's intratracheal, so giving it down the endotracheal tube. So the drugs that can be given that way would be epinephrine, vasopressin, and atropine. They do vary a little bit in their doses. So for epinephrine, you'd be giving it at 0.02 mg per kg, and for atropine, you'd be giving it at 0.08 mg per kg, and those would be diluted. And then for vasopressin, it would be 1.2 units per kilogram for our patient. So those are some other ways that those drugs can be given if vascular access can't be gained. All right, so finally, there are a couple of mistakes in this video that I didn't realize until after recording. So the first is that the drugs that I called out, I had called out for the wrong weight. So we were supposed to be doing this for a 30 kilogram patient. I called out the drug dosages for a 20 kilogram patient. So that was one mistake that I had made. Also, the person that I was directing to give those drugs just wasn't repeating those things back to me. I could have instructed them a little bit better beforehand, but that was just kind of one thing that I had noticed in the video as well. And then lastly was the ECG leads weren't hooked up to the patient prior to the video starting. If I could change one thing, it would be having those connected before starting the compressions on the patient. Anyways, please enjoy this video. This is our CPR demo. So I have Dr. Krista Foreman as my clinical mentor helping me out, as well as Dr. Hannah McKellar. Kim is behind the camera, and we're also going to be having Courtney help us. So we are ready to get started.
Lie down.
Oh no! All right. We got him in lateral. Okay, so we're immediately going to start compressions. So I'm going to start compressions at 100 to 120 beats per minute. I want to do 1/3 to 1/2 of the chest width, and I'm going over the widest part of the chest where it's a large dog. Meanwhile, I'm going to get Krista to intubate while I'm doing that. All right, are we intubated?
Intubated.
Perfect. All right, so Krista's going to start ventilations at 10 breaths per minute.
10 breaths per minute.
Meanwhile, Courtney, I'm going to get you to hook up our ECG and our end tidal CO2.
30 seconds.
All right. If you just want to grab those cords right there. Perfect. All right. And we're attached. Perfect. And we have end tidal CO2 going. Perfect. All right, we're going to keep going for a full 2 minutes.
60 seconds.
All right, as well, Courtney, I'm going to get you to gain IV access. Perfect. You want to make sure, too, that we're allowing full recoil of the chest. And that when Krista is ventilating, that we're not ventilating at the same time that I press down on the chest. All right, so we're gonna get ready to switch here in about 30 seconds.
$15 seconds to switch. All right, switch it up.
So at this point, we're going to monitor our ECG. We'll see that we have no readings and there are still no heart sounds. So Krista and I are going to switch, and we'll resume compressions. All right, Courtney, I'm going to get you to drop 0.2 mils of epinephrine, please. All right, 0.2 mils of epinephrine drawn up. Please administer. All right, epinephrine administered.
30 seconds.
All right. Where are we at for time?
1 minute.
Perfect. Keep going.
Is
90 seconds.
All right, so we're gonna get ready to switch here again.
seconds to switch. Alright, switch.
All right, so we're gonna monitor our ECG again and take a listen. And we'll still see that our patient still has no heart rate. So we're gonna continue compressions and ventilations. Meanwhile, Courtney, I'm gonna get you to draw up 2 mils of atropine, please.
2 mils atropine.
Perfect. And please administer 2 mils of atropine. Perfect.
30 seconds.
Good.
Has anybody talked with the owner?
Yeah, I have him on phone right now.
All right, tell him the situation.
1 minute. You can make it, little lion. Little Mufasa was trampled. "90 seconds. Got this, Kirsten. Alright. And 2 minutes.
All right, and we would listen again, and still nothing, and the owner has decided to withdraw CPR attempt.
Time of death 3:19.